So just to introduce myself, my name's Lottie. I'm the Communications Officer at the Pituitary Foundation, and I'm going to be the chair of today's session. And I'm also joined by Megan from the Pituitary Foundation, who's going to be doing all of the behind the scenes admin support, and anything in the chat will probably come from her. And then I'll introduce the person answering all your questions a bit later. So just to go through the housekeeping, so we have enabled closed captions, so that means you can see what we're saying as we say it. So if you'd like to use that, then you can click the button that says CC at the bottom of the screen. For those of you not familiar with the Pituitary Foundation, we provide support for the 70,000 plus people in the UK who are affected by disorders of the pituitary gland, as well as their families, friends and carers. We want to ensure that every person affected by a pituitary condition has a timely diagnosis and access to high quality treatment, information and support. We have a dedicated nurse helpline, online and printable resources, and we work with leading medical experts to improve patient care. So I'm really excited that we're having this Q&A today as part of our Pituitary Awareness Month programme. And some of you might have joined in some of our previous sessions. But if not, then it's definitely worth signing up to some of the sessions that we've got going on because they're already great. So for those of you who are not using visuals, I am a mid-20s woman with brown hair and I have blonde streaks in it, and I'm wearing a cosy jumper today. This session is being recorded and it will be available on our website later in the year. But no one's faces or comments will be visible unless you want to ask a question and you have your camera on. And we want to ensure that all our events are welcoming and accessible for all, especially as there may be personal experiences discussed in this session. So we do ask that you keep yourself on mute when you're not talking, just so that we can manage background noise. And you don't need your camera on if you don't want to, but it would be lovely to see faces if you're comfortable sharing. You may wish to add pronouns to your name so that we know how to refer to you. As you can see, both Megan and I have included ours. And to chat, we are asking that you ask questions and use the chat bar to chat today, just so that ensures that we can get through everyone's questions. Because obviously we want to make sure we answer everyone's. And we are expecting this session to finish at around 5 o'clock. But feel free to leave the session earlier. If you've got somewhere to go and you've had your question answered. So yeah, I'm very excited that we're joined by Dr Antonia Brooke today. So would you like to introduce yourself?
Hello. Hi. I don't know if I'm on the screen or not. Am I? Yes, I'm up there anyway, so I probably am. So I'm Antonia Brooke. I'm the clinical lead of endocrinology at the Royal Devon University Hospital Trust. I have to concentrate on that because it's a newly formed trust between ourselves in Exeter and our colleagues in North Devon. I'm also a trustee of the Pituitary Foundation, and I chair the Specialist Advisory Committee for Training registrars. So these are people coming through that have already chosen to do endocrinology as a specialty, and then they have their training to become a consultant. And I also chair the peer review for the Society for Endocrinology, which is essentially going around to lots of different hospitals and looking at how they're delivering services and seeing if we can help them to do a better job or take the ideas that they're doing well and try and share those with other centres so that there's some equity of care across the patch. So yeah, I'm really excited to be here. Thank you for inviting me, and I will happily take any questions, however stupid you may think they are, and I apologise in advance if I'm not able to answer them, but if I can't answer any questions, I will definitely find someone who can.
Thank you so much for that. So we have had some questions sent in by some of our members, so we'll go through those first. So our first set of questions is sort of all relating to COVID. So it's quite a long bit. So it says, this person is unvaccinated, which is not due to their pituitary condition. And they were diagnosed with lymphocytic lymphocytis during
You did quite
lockdown.
well. Lymphocytic hypophysitis.
Oh, well, you knew what I meant. So they were diagnosed with that in the first lockdown after they'd given birth to their first child. As they were diagnosed during lockdown, the advice was quite strict, so they shielded. However, they sort of want to know what they should be doing to sort of, as the rest of the world moves on with life after COVID, how should one live life post-pandemic and through future flu seasons for years to come, yet still be safe?
So I am presuming that if this person developed lymphocytic hypophysitis, that they have a deficiency in some of their hormones. Not everyone does with lymphocytic hypophysitis, but the most common hormones that people have a deficiency with are estrogen, so they don't get their periods back, and cortisol, so that they need hydrocortisone or prednisolone to keep themselves safe and out of hospital, and sometimes levothyroxine and sometimes growth hormone. And then sometimes with lymphocytic hypophysitis, you also get cranial diabetes insipidus, or now to be known as AVBD, which if anyone hasn't heard that on a previous talk, then I can talk about that perhaps afterwards. So I'll assume that's the case. And I guess taking loads of little bits of that together, I suppose the first thing just to think about is, hi Tracy, the after COVID. I think the first thing to say is there is no after COVID. I think the government's strategy was based on, getting COVID out of the way and then everything would go back to normal. But I think it's becoming more and more obvious that this will just become like another flu, and we'll continue to have waves. And right now we're in the middle of, particularly in the southwest down here, we've got the highest rates in the country at the moment, and we're in another big wave. So in terms of how you can protect yourself, there's a couple of bits to this. Obviously, my role as a physician is to say that the safest way to protect yourself is to get a vaccination and keep up with your vaccination program. But if you're unable to do that, or you've got your own personal reasons, that's, obviously your bag, and I'm sure you've considered the pros and cons of that. If you are just having had a baby, chances are you're younger than me, and therefore, by definition, you're already in quite a low risk group from having COVID. And you might say, well, hang on, if I'm on hydrocortisone, how's that put me in a low risk group? The age is the single biggest factor in COVID that is going to do you damage. So whilst being hypopituitary is a worry, it actually is not that much of a worry. And right at the start of COVID, we said, oh gosh, well, anyone that is on hydrocortisone, lots of people got those you need to shield letters. And part of that is because there was a blanket thing that went out through pharmacies that anyone on steroids prescriptions got this. And that's because there's lots of people out there on steroid prescriptions that are on very high doses. And those very high doses cause immunosuppression. So that suppresses your own immune system and you're not able to fight infection. So there's lots of people that have arthritis or asthma or all of these other conditions where on really high doses, and we thought that they would be very, very vulnerable to infection. And that's why some people got shielding letters. The people on replacement doses were never particularly in that very high risk group. So they were in the next risk group down anyway, even at the start of this. Now, as time's gone on, we've also realised that those on steroid replacement, steroids are quite a good thing in COVID. So actually, you're probably not going to be in a particularly higher risk from a COVID point of view. The main worry is that you're hypopit and therefore you're at risk of adrenal crisis in whatever you do, if you become very unwell. So whilst your actual risk of getting ill with COVID isn't probably that much worse than if you've got diabetes or you're older in an older age group, or you've had a cancer treatment, or there's been something else going on, Your risk is that when you get unwell for any reason, you need to know your steroid precautions, and you need to know how to look after yourself, particularly if you end up needing to go into hospital. And then the other thing that I say, and I say this to my parents all the time, is actually just keep an eye on what's happening with the waves of COVID. So I know I'm not wearing a mask now, but for the last couple of weeks, I've been wearing a mask everywhere. So if I'm seeing patients in clinic, I'm wearing a mask at the moment. And if I'm going into a group of people, I wear a mask. And that's for two reasons. One, because I've had COVID more times than I want, and I don't really want to get it again. So if there's anything I can do to protect myself, then I'll do that. And the second reason is I live in a house with teenagers, and therefore, with the best will in the world, I may well get COVID and either not realise it, or not realise it until I've passed it on to someone. And if I can do anything at the moment when I know the incidence is high to protect people, then that's easy for me to do. So that's why I wear a mask. And also there's certain situations where I always now insist on my family wearing masks. So if we go on a flight or something like that, I suggest that we wear masks and things like that. So there's those simple things that you can do to minimize your risk of catching it, and disinfectant really does work. But I don't think you need to be overly alarmed in itself just from the COVID. And the final caveat, sorry, I know this has been a very long answer, but in some ways it probably it relates to a lot of people. The final caveat is if you have had a pregnancy, then you may be wishing to have another pregnancy. And that is the biggest worry, because the other big risk category for people who have chosen not to have a vaccination is pregnancy. So the third trimester of pregnancy, the last bit of pregnancy, we know that is a really high risk period for people who get COVID. So I'd say if you are really sure that you don't want to get vaccinated, and you want to get pregnant, the best thing you can do is time it to a time where COVID is low, but that's often very difficult to predict what's going to happen 9 months in advance. And then just that last trimester of pregnancy, being really, really careful about what you do and how you look after yourself in terms of infection and prevention and control. Does that answer the question?
Yeah, I'm sure that has answered that person's question. That was very thorough. And I'm sure they feel reassured that they're not as perhaps vulnerable as they were told in that first lockdown. So sticking with the sort of COVID theme, another question we've had sent in is sort of, since the COVID pandemic, what changes to the service might I expect? Well, I assume by this they mean the service of sort of their normal endocrinology service.
Yeah, that's absolutely right. So many people will have noticed in COVID that their appointments got cancelled, or they got changed, and without doubt there is now a significant delay in delivering those appointments. And right at the start they were cancelled because everyone was really worried, but there was also a lot of training that had to happen. So we trained people to do things differently, and a lot of us, particularly endocrinologists, most endocrinologists are also acute and general physicians as well. So most endocrinologists actually went on the COVID front line, and we were all on COVID wards or looking after general medical patients that weren't on COVID wards while someone else went on the COVID wards. So it was really difficult for a long time for a large number of people. And from the training perspective, a lot of those registrars are still working on COVID wards and are still doing all of that. So that's why the appointments tended to get cancelled. But then in addition, there were lots of restrictions put on us in terms of how we delivered them. So all of that packing you in like sardines into a waiting room was no longer allowed to happen. And we had to observe social distancing and things like that. So that meant we couldn't have as many people turning up to outpatients. So that meant we couldn't see as many people face to face in outpatients. Now, most of those restrictions have now gone. So those limits are not necessarily there. But during the time of COVID, and actually this was a drive from the government even before COVID started, we started doing video and phone appointments. And excuse me 1 second, my daughter's just come in. Charger? No, it's always about a charger, isn't it? anyway, we started doing video and phone appointments. So in various national surveys, there have been people saying that about 40% of people actually prefer to have that virtual appointment if they can, so either a video or a phone appointment. And in Devon and Cornwall, that's a massive thing, because obviously we have to travel huge distances to go up and down to the clinic appointments, and a lot of people actually choose to do that. In our clinic, we offer a choice, so you can do what you want, and that works for most people, and we have the advantage of community hospitals where they can do bloods a little bit more locally and things like that as well. So that has definitely changed, and it's definitely here to stay. And actually it fits quite nicely with the green agenda, because it's phenomenal. I don't know if you know this, but it's something like a third of energy in the UK is used within the NHS. And that means not only in terms of us all turning the lights on and the fans on and the computers on and everything like that, but actually also in terms of patients travelling to appointments and back, and, you know, blood going up the motorway and everything else that's going on. So actually, from a green perspective, if there's anything we can do to reduce that, it's also a really good thing. So those things have definitely happened. And then the other thing that you might be offered in your services is something called a PIFU appointment, which you may read about as well, which is called patient-initiated follow-up. And that's actually a really good thing for people who are educated, and by definition you are here and will be educated and motivated to look after themselves. That is essentially giving you usually a long stop appointment somewhere down the line, and then saying, listen, if you're fine, this is what we're going to do. We might do your bloods every year, or we might not, or whatever it is that you need. And then if you're unwell, then you can bring that appointment forward, so that you have a little bit more flexibility in when you see the doctor, rather than what often happens, which is you see somebody at a time, you don't really need it, and then when you try to get back in the service, there's a 6-month queue to get in, and it's really not working for you. And actually what that also does is release some space for people that need to get into the service quickly, who may not be prioritising their health in the same way. And actually we need to look at how we're providing that equal care for everyone. Certainly in Devon, we know there's a 15-year age gap between those that are doing well in their health and those that are doing less well in their health. And it's a real problem, and something we really need to look at why that is.
Thank you. That was very interesting. So the next question we've got, which is one that I think we get quite a lot, is one of the concerns regularly from people is that they worry about feeling safe when admitted to hospital. Can you reassure people about what is going on to improve that? So I assume they mean when admitted to sort of a general ward.
Yeah, so there's two bits to this. When you're admitted, well, three bits, I guess. When you're admitted through the emergency department, when you're admitted under, you know, another service. So if you're having your hip done, or your, you know, appendix out, or, you know, neurosurgery, or whatever else it may be, and then when you're in under the endocrinologists. And I think there are several things that are being done, and we need to look at it again from both angles. So if you take the patient pathway, so what you should know as patients, then as patients, it is perfect if you're on steroids. I'll go steroids first, and then I'll go to diabetes insipidus and DDAVP, AVPD. But if you are on steroids, then you should have been taught the sick day rules. You should have a new red steroid card, and you should ideally be able to know how to inject, or have a member of your family that knows how to inject IM hydrocortisone if you need to. Then the additional things that varies a little bit where you are in the country are alerting the ambulance services, alerting the out of hours doctors, and in some places alerting the emergency departments. That's changed a little bit in the sense that the ambulance services have actually asked that we don't necessarily alert them, because they say that all paramedics and things now carry hydrocortisone. I have to say, in the Southwest, we contacted our local ambulance service and said, do you want us to stop doing that? And they said, actually, no, we want you to still do it. So we are. But I think in other areas of the country, they're saying, actually, this is just happens automatically and you don't need to be doing that. So there's probably some variance in that. And then the other thing that's happened is something called the National Patient Safety Alert, which is basically a governance structure. So reporting if there is any incidents of harm or potential harm that come to patients if they come into hospital and they aren't given their steroids appropriately. But also every trust now has to guarantee that they can identify patients on steroids and that they have a system of flagging up those patients so that they don't miss their steroids. And that is new, and it should make things better, certainly in the longer term. And the more patients, the more trusts get onto sort of these electronic patient records where everything's online, the easier that becomes. So any trust that's got electronic prescribing, we've just got this in the last couple of years. Essentially, if someone puts, if a nurse puts as a X in the box for not giving you your steroid, there will be something that flashes up to that nurse saying, this is not a drug that you can miss. Why are you missing it? You need to contact a doctor to make sure that you're not missing it. So that should make it better. And then most endocrinologists, if they've got an InReach service into them, into other services, should be or could be contacted if you feel that you're not being listened to in that way. So I think things are a little better. And then there's some caveats to that. And one of the main caveats, and I've talked about this a reasonable amount actually, is I think compared to where we were, 20 years ago when I started my training, in fact, longer than 20 years ago, but we used to have very much this sort of model of, the professor of medicine that would stand at the end of the bedside and scream at the patients, and the patients would bow nicely and do as they were told. And as juniors, we would, bow and do what we were told, and the nurses would bow and do what they were told, and that just doesn't happen anymore. Much as I would love my juniors to bow at me, none of them do, but actually we have much more of a partnership with patients, and that is a really good thing. And part of that partnership is also about making sure that patients understand where we're up to and what is right and wrong in all of this. So one of the really difficult, I think, and challenging bits of that is adrenal crisis, because adrenal crisis is not clearly defined. You can't, there's no sort of magic, oh, I'm in adrenal crisis, I'm not in adrenal crisis. So there's things like your blood pressure and your pulse and things like that that really help us to know. But actually people interpret it very, very differently in terms of whether they're in adrenal crisis or if they're not in adrenal crisis. And also that happens in ED departments too. So when you have a triage in the emergency department, if your blood pressure and your pulse is fine and you've managed to keep some steroids down earlier, or you've had an injection, you may be triaged not as a first priority. And at the moment, EDs around the land are full. And there are people that are not getting in with their heart attacks or strokes or whatever, who will be prioritized ahead of people with normal pulse and blood pressure, even if they think they're having an adrenal crisis. And I think we need to have a really honest conversation with people about that it is really important that is recognized as essential. But at the same time, it might be that you're really safe and actually you're fine to wait, and it's not optimal, it's far from ideal, but your life is not in danger because of that. And actually, I think that's important for people to know, because I think one of the biggest worries is sitting in that emergency department thinking that they're going to die any second. So you need to feel confident that the person that has assessed you understands adrenal crisis and has made an assessment that is based on good information that's accurate. And I think that's probably getting better in many places, but it's not perfect in every place. And I think it would be silly to say that it is. So that's steroids. In terms of AVP, so diabetes insipidus, the AVP that I keep saying is because if many of you will have heard, I'm sure already, but there is a real push to try and change the name so that you don't get your finger pricked for diabetes when you come into hospital. That is one part of trying to make it safer for people with diabetes insipidus. As you know, if you've got it, it's quite complicated as a condition, and most doctors and nurses in hospitals will never have seen someone with cranial diabetes insipidus. And I think a lot of people often say we really want people to know more about it. I think that is a really difficult challenge, because there are so many people coming and going within medicine and, you know, junior nurses and everything else, to try and reach to every single person and help them to understand what it is, I think would be really, really difficult. So we have to make sure that patients are informed, and then we have to put, you know, practices in place to make sure, like with steroids, that actually if someone decides not to give you your medicine, or makes you nil by mouth because you're having a procedure or something, that they've thought about it and that they've contacted the endocrinology team to get advice and that it's monitored. So those are the things that are happening. Some areas are doing it better than others, but without doubt it's challenging times at the moment, I think.
Cool, thank you for that. So our final question that we've had sent in is growth hormone treatment effective for a 74-year-old man? So I'm not sure on the specific condition here.
Yeah. 75, no, 73, yes. No. Yes, if you have growth hormone deficiency. So if you look on American websites, you know, for anti-aging things, then you can see lots of adverts for growth hormone as you get older, to keep you young and beautiful and all the rest of it. Most of them are tablets, and growth hormone is destroyed by stomach acid. So immediately you're wasting your money on that. And the reason for that is because growth hormone declines with age. And so the natural thought is, well, if it declines with age, if we give growth hormone, then we can just top up what your body is not making for itself. And there is absolutely no evidence that that works at all with normal age-related decline in growth hormone. If you have growth hormone deficiency associated with a pituitary condition, that's very different, because with the decline in age, you get a drop in your growth hormone, but you still get the sort of peaks and troughs that you get with growth hormone. It's just at a slightly lower level. Whereas when you have your pituitary taken out, or you've had it irradiated, or whatever it is that's caused you to be deficient, you lose that, and you lose the peaks and troughs. And actually, there's really good evidence that elderly people who have symptoms associated with growth hormone deficiency, not that 74 is old, but even in 80-year-olds or 90-year-olds, that actually replacing growth hormone, if they've got symptoms associated with deficiency, can be really effective. There are a few caveats, which is that you need to have your risk of diabetes assessed, and you need to have your blood pressure and your lipids watched a little bit as well, because it can affect some of the other hormones, and actually some of the other hormones may need adjusting when you start on growth hormone, just to make sure that they're all replaced well. But yes, there are plenty of older age people who benefit from growth hormone. There is a lot of interest in growth hormone again at the moment. There's an audit, I think, going on in Birmingham about how we are reassessing people that have been on growth hormone for many, many years, and whether it has the same benefit if they've been on it for 10 or 20 years, because we're getting to that stage now where quite a lot of people that were in the original growth hormone trials are now 20 years down the line and still on growth hormone. And is it still doing the same thing? I think that's out there as an ongoing question, and there's lots of debate about it at the moment.
Cool, thank you. So we'll go into the chat box now. So we've had this question in from Chris. So they've said that they are hypopit, so they have a pit apoplexy last year at age 59. Is there a recommended interval for them to have a pituitary panel blood test? For example, would they need one every 3 years?
No, is the short answer. So it depends on how big your original lump in your pituitary was, and how big the bleed was. So I think if you had an apoplexy and you are hypopit already, and put on replacement, then actually you just need to check that your replacement is in that realm. Very, very occasionally people can recover function as that apoplexy, as the blood. Apoplexy is blood into the pituitary usually. Sometimes it can be an infarct, like a blockage, but usually it's a bleed. If that blood resolves, sometimes you can recover your own pituitary function, but most of the time you don't. So if you're established on treatment, then you just need to know that that treatment is right. And then for most people, you don't need more than a once yearly blood test to make sure that it's in range. If you weren't originally hypopituitary at the time of that blood test, well, it depends on all of those things that I've just said. So how big a bleed it is. If you had quite a big bleed, I would typically check again within a few days. And if it's still normal, I'd check again at about 6 weeks, and then probably at about 3 months, something like that. Whereas if it was quite a small bleed, or you had very normal function and you're feeling well, it may be that you just do another test after, you know, a few months' time down the line. So I don't think there's any precise protocol for that. It depends very much on what it actually was, and how convinced people were it was a, you know, a big apoplexy, rather than, you know, sometimes people say apoplexy when they're not sure, but you've had a big headache and it's compatible with it. So yeah, no, it's quite variable.
Thank you. Hopefully that's answered your question, Chris. We don't actually have any more questions in the chat, but I'm sure some people are typing some out now. So we'll just hang on.
I'm excited to see that you're holding a session on preparing for staying in hospital. I think that's a really great session. Yeah, and I do think one of the things I think would be, you know, really great is to have, you know, people that are really confident and have lived through that experience and know how to do it, to help share that information with other people as well, because it, without doubt, it always comes up, doesn't it? And it's always a really, really frightening thing for people. And the bottom line is I think it is definitely better, and I definitely don't think anyone should rest on their laurels, and I definitely think it's highly variable in different trusts. You are in the massive advantage as a group of people that have turned up on a Friday afternoon to listen to me answer questions, in that you're interested and you're obviously intelligent, and wanting to learn and know. And therefore, if you go into hospital and you're not getting what you think is right, you'll make some noise until you do. And that's not to say that that's what you have to do, because you should have to, and all the rest of it, but often that is something that, you know, people find of some comfort if they can do that, and it's very reasonable to do that. I guess what is really important is that we are making that noise for people that don't make that noise, to make sure that it's totally safe for everyone.
Definitely. All right, awesome. We've got a question from Tracy. So she is on Matrophen. I assume that's a drug. Excuse my ignorance. And she has come down from 50 milligrams to 18 milligrams, and she's found it very hard coming off this drug, and she's feeling a bit low. Is my hypopit affecting, or is it the other way around? So
Matrophen is fentanyl, I think that's a trade name, but I think it's a fentanyl, so it's a painkiller, an opiate based painkiller. So opiates in themselves obviously have some addictive properties, and therefore you're not alone in finding it difficult to come off fentanyl. It will also suppress your own residual adrenal function. So if you are not hypopit and you take fentanyl, then your cortisol levels can go down a bit. So we sometimes see people developing cortisol deficiency on opiates, on fentanyl or morphine sulfate, or some of the higher, stronger painkillers. If you're already established on hydrocortisone, it shouldn't really make much difference in how it's metabolized. So you should be getting that steroid into your system. And likewise, I don't think it has any impact on things like your thyroid hormone. It doesn't on the thyroxine itself, but I don't think it has any impact on how thyroxine is metabolized or anything like that. So it's probably more likely, to be honest, the coming off of the morphine than it is anything else, which is normal for people coming off. Sorry. You've probably, I would guess, been on it for a reasonable length of time as well. So that in itself can make it harder.
Yeah, she said that it was for her hip, but she has had an op now.
It may well be why you're feeling a bit unwell. Yeah. I mean, you know, opiates, so fentanyl, MST, are are full of side effects as well as the benefits that they give in terms of painkillers. So yeah, it may be, and also if you come off them too quickly, then you can absolutely get withdrawals as well. So it may be that as well.
All right, well, hopefully you start to feel a bit better soon, Chasey. So Chris has come back again, and they've said they're still a bit confused as their readings for T4 keep dropping as their growth hormone goes up.
Yeah, that happens. Growth hormone intervals, there's a really good Me and My Hormones on this, I think it's on the SFE website, the Society for Endocrinology website. But if you start on growth hormone, it affects various other hormones. So it'll affect your thyroxine hormone, it can affect your cortisol, bits of your cortisol hormone, something called the cortisol binding globulin. It can affect estrogen if you're on tablets, estrogen, less so if you're on a patch of estrogen. So when you start on growth hormone, it's important to check those other levels. And absolutely, if you go up on growth hormone, you might need to go up on thyroxine as well.
Perfect. Okay. I don't know if anyone's got any more questions to add in to the chat, or
I can write it in here. I better check that it is there, but I think if you look on Society for Endocrinology, You and Your Hormones, I'll try and find it, but let me just see if I can. You and Your Hormones from the Society for Endocrinology. There's probably one on growth hormone. I've read it somewhere recently and thought, oh, that's a really good explanation for, or maybe was it in the Pituitary maybe it was in the Pituitary Foundation magazine. That's bad, isn't it?
We did have an article about how your hormone replacements impact other hormones.
There you go. It was in the Pituitary. Read that. You see, it's great. Yeah, I think it is also probably there, but I can't find it on a Google search anyway. So if you get the Pituitary Foundation newsletter, it's in that, and that explains it all. There's quite a lot of science in there, but it's a really good article. And if not, then I'm sure Lottie can give you the way of getting that if you haven't got that magazine.
Yeah, we do have a link to it. I think I've just found it here. We'll be pleased to hear we are getting a new website, so hopefully it'll be much easier for everyone to navigate, including me. Okay, so we've just had a question from Mark, who apologizes for being late. No worries, Mark. He has asked, what is the current advice for hydrocortisone dosage in the case of a positive COVID diagnosis? Because there has been some debate about this.
Yeah, I can tell you what my current advice is, because there hasn't actually been any reform of this. So this came at the beginning when there was very little evidence about what to do in COVID and no one had been vaccinated and all the rest of it. Then the advice was that you went up, essentially more than doubled. So for most people, that was going up to 20 milligrams or 2 tablets of hydrocortisone up to 4 times a day. And that was based on the fact that there were lots of fevers going on overnight, all the way through the night, and that people were getting really, really sick. Now, most people now have been vaccinated and a lot of people don't get very sick. And therefore, I would say it's the normal sick day rules for most people. And that is usually fine if you are feeling like that. But it comes with a big caveat. If you're unwell with COVID, there is absolutely no harm in increasing your steroids. And in fact, if you end up getting breathless with COVID and end up coming into hospital, you will be given very big doses of steroids because there's evidence that that works. So actually, you can't go wrong by giving yourself a decent amount of hydrocortisone if you know this is COVID and you're really unwell with it. So whilst you might not need it, if you're actually just, got a bad case of flu type COVID and you're just sitting in bed, you might just double, and as long as you're sleeping through the night and you're not having raging fevers all the way through the night and things like that, double's probably fine. But if you're really unwell with it, then absolutely go to more. And as I say, if you end up going into hospital, you'll end up getting buckets of steroid anyway, so you're unlikely to go over.
Yeah, Mark has said thank you very much, that's really helpful, and I hope you get better soon, Mark, and you're not too poorly with COVID. As he said, he's positive right now, so
oh no.
Yeah, hopefully you're not too bad if you've been able to join. And Megan's also shared a link to the Pituitary Foundation sick day rules in the chat, which I'm sure most of you have seen before, but it's always worth catching up. And we also do have another session as part of Pituitary Awareness Month on the sick day rules, which was with our endocrine nurse Pauline. So that's also worth joining, because I think it's always good to have sort of remind yourself on the sick day rules. So our next question comes from Jane. Hi Jane. She has asked, can a reduction in or I assume she means thyroxine dosage cause muscle weakness and sleep disturbance?
So probably not. It depends a bit on if you're on lots of other hormones. So directly from the thyroxine dose itself, probably not. The muscle weakness is typically, and sleep disturbance, you typically get it the other way around. So people that have an overactive thyroid tend to get muscle weakness and tend to get a bit of sleep disturbance, rather than an underactive, so a low dose of thyroxine. There are some people that don't feel completely well on thyroxine, you know, so that might disturb your sleep a bit, I guess. But I would say it would be very unusual for a reduction in thyroxine dose to cause muscle weakness and sleep disturbance on its own.
Okay, thank you. So we don't have any more questions, so we'll just wait a bit to see if anyone else has got one to ask. But please do pop it in the chat. Okay, so someone else has asked about the COVID booster. What is Mark again? So I see Addison specifically on the government website now for the first time, but not secondary adrenal insufficiency. My GP was unaware of any change, and I have got a letter issued now from my specialist. But what is your understanding of what should be the case? So whether they should be getting, someone with secondary adrenal insufficiency, whether they should be getting the COVID booster?
The honest answer to that is I don't know, because I don't know. It certainly wasn't that we were getting the COVID booster. The nurses would probably know this more than me. So certainly when the initial announcement was made about COVID boosters, then it was the older age group and healthcare workers. So if you're saying that Addison's are now specifically, that usually covers adrenal insufficiency because people don't differentiate between the two. But I'd be surprised if that has been separated out, because I don't think there's any really good evidence, which I did talk about a little bit earlier, Mark, but I can easily repeat it, just about actually, you know, your diagnosis putting you at particularly high risk of having a bad outcome from COVID. It doesn't look, it's harder because it's a rare condition, but compared to people with sort of diabetes, hypertension and the elderly, then actually those are much bigger risk factors than having hypopituitarism. On top of that, the main risk is what you all live with anyway, which is the risk of you having an adrenal crisis because of your hypopit if you're unwell for another reason. So it doesn't, if you separate the two, it doesn't make you worse from a COVID perspective, particularly, it seems. You know, but it you know, like any other illness that you may have, it's just the consequence of your hypopituitarism that means that you might end up, you know, with an adrenal crisis if you're not managing your sick day rules properly.
Okay, thank you. Yeah, Mark, you didn't really miss out on that earlier. We did have quite a lot of talk on about COVID, but this session is being recorded and we'll be sharing it on YouTube and our website in probably November time, so you can always catch up then. So a question from Kimberly is, how common are fevers as a symptom of low cortisol?
Not is the straightforward answer. So if you have fevers for another reason, and you're very unwell with it, then you might want to look for a low cortisol. But having fevers as an experience of low cortisol, I'd say, not common.
Okay, thank you. All right, I don't think we've got any more questions. Oh, every time I say that, one pops up. So Chris has asked, I've been referred for guided steroid injection to hip and spine. Will this affect my replacement hydrocortisone?
No. So if you weren't on hydrocortisone, but you had a slightly borderline level of steroid, then it might do temporarily, and people with a hip injection, steroid injection, should get steroid cards, because it can temporarily suppress your own adrenal function. Typically it's quite short-lived. If you're on steroid replacement anyway and you're on a decent dose, not just a little top-up, you shouldn't need any more if you have that, and it's absolutely fine to have it. It's no problem.
Thank you. I think you mentioned the steroid card there. I'm not sure. Hopefully Megan can find a link and pop that in the chat if you're not aware what that is. But it's a sort of a little card that's like credit card size that can go in your wallet, and then you can show it to a medical professional, and it's got a little QR code on it that links to the society, a page on the Society for Endocrinology's page about what to do if someone is having an adrenal crisis. So yeah, we would recommend carrying that if you have Addison's or adrenal insufficiency. Oh yeah, another question from Mark is, do you advise having more than one emergency kit, and if so, is that easy for us to obtain? They said perhaps a kit at home and a kit at work.
Yes, I think it's sensible. Having said that, there's some people that have had one emergency kit, obviously changing it when it runs out and it expires, and they've never used it in 40 years or whatever. So, some of that depends a little bit on how good you are at carrying things around with you and organized you are. If you know you're going to forget it, then it probably does make sense to have, one in different places. Certainly for people that are in long-term care institutions, so a lot of our teenagers and young adults and things like that, that might be, blind with hypopituitarism and things like that, then we'd always keep one at their sort of school, college location, and one in their home location and things like that. So it should be that the GPs could give you that, or that your local endocrine service can give you a second injection if that's helpful. If you're good at remembering to carry it around, and or you've never had an adrenal crisis in, that you've needed a steroid injection for 20 years, then probably not. Yeah.
Yeah, thank you for that. There is quite a lot of information on the Addison's disease self-help group. They have a lot of information about the emergency kit. So I would definitely recommend having a look at their website for that one. And Tracy has said, it's still very hard to get the liquid instead of powder. Any news on EpiPen for hydrocortisone?
No, you're right. It comes and goes, the liquid versus the powder. So sometimes it's in and sometimes it's not in. And it has been coming and going a bit. In terms of the EpiPen, the problem is that it's just not common. So there's no financial incentive for a company to develop it. So I think the chances of it getting developed into an EpiPen is really small, is from what I hear. So I think it's unlikely to happen, to be honest. But it would be good, wouldn't it? Because I think everyone recognises the difficulty in terms of drawing things up.
Yeah, that's definitely something that because I manage the Pituitary Foundation social media pages, and that's definitely a question that comes up a lot about the sort of having
it is. So I don't think that, so there's a steroid group that runs as part of the Society for Endocrinology, and those sort of things are discussed regularly, and I think last time that was discussed that I heard about it, the feeling was that there's no company that's going to take that on and invest in it, because it's not common enough to make it profitable, essentially. So it's unlikely to get legs. I'm going to a meeting on Friday, actually, so I can ask next Friday, or week on Friday, so I can ask, because I know there's someone from the steroid group there, so I can ask if anything's changed on that, but I don't think it will have done.
Perfect. So we are coming to the end now, we'll just hang on a few minutes in case anyone has got any more questions. They have been very good questions. I feel like I've learned a lot, so I hope everyone else has too. Especially my pronunciation of some of the...
You've done really well.
Thank you. So I think, we've had another question from Jeff. My GP is unable to get FT4 result. Is this the norm?
No. So that either your GP is not writing hypopituitarism on the form. If they write thyroid function on the form, then they will only get a TSH, because for the vast majority of people with thyroid dysfunction, that's because they've got a problem in their thyroid, and a TSH is adequate for most people to judge that. If you've got hypopituitarism, then obviously that isn't the case, because the TSH comes from the pituitary gland, and so you probably won't be producing it. So you have to measure the free T4 as you suggest. Now, if you write hypopituitarism on the blood test form, there isn't a biochemist in the land that wouldn't then process if you have also asked for a free T4. So if there is a problem with that, they need to phone the biochemist and make sure, but I suspect it might be because no one's writing on the for hypopituitarism, or they're just asking for thyroid function, and you'd need to specify free T4, and you'd need to specify hypopituitary to get that reading. Which is a constant problem. It has been a long-standing issue that many GPs see a low TSH result, which is the pituitary gland hormone, and start reducing people's thyroid hormone, and we have to battle quite a lot with GPs just to remind them that actually you can't take a low TSH reading as meaning anything, because the body's not producing the TSH. So you're absolutely right, you do need that free T4, and there's no reason why your GP shouldn't be able to get that if it's needed, but it may be that they're not writing the right thing on the form.
Okay, thank you for that, Antonia. Hopefully that answers your question, Jack. Right, I think if we don't have any more questions, then we'll just sort of finish up there then. So I think Megan will hopefully have some links to put in the chat now. So obviously this is part of our Awareness Month programme. We have got lots of other talks, some of which we've already spoken about today, and I think some of the things that have been discussed today, it sounds like people would find those other sessions useful. So I would definitely recommend attending some of those other sessions. And this session, as we've already mentioned, and all of our Pituitary Awareness Month sessions are going to be available to watch in November. I believe we'll be putting them up on YouTube and on our website. So you'll be able to watch back any of the sessions that you weren't able to watch live, or if you want to rewatch this, then you can. And the best way to keep up to date with that is to follow us on social media, and keep an eye on the website and things like that. So our website is www.pituitary.org.uk, or you can just Google the Pituitary Foundation and will pop up. So we are also just want to say that we are offering these sessions for free, and if you found this session useful and you are able to, we would really appreciate a donation to help us keep these sessions free and accessible to everyone. So hopefully Megan will pop a link in the chat now, or you can text Living Well 10 to 785, and that will donate £10, and those texts cost £10 plus one standard rate message. And thank you to everyone that has already donated, because I'm sure that some of you already have, and we are very grateful for that. And finally, I just want to say a massive thank you to Antonia I have learned so much, and I'm sure everyone that joined has learned a lot as well. So we are very grateful for you giving up your time on a Friday afternoon to come and talk to us and answer everyone's questions.
It's a pleasure. It's a pleasure to be here.
And yeah, that's the end of the session. So thank you so much everyone for joining, and hopefully we'll see you at another session later in the month.